Hello, everyone, and welcome to the Protecting Our People podcast. This is a series of discussions about the problem of violence in home health care. I'm Dr. Danielle Parati, registered nurse and clinical associate professor and director of undergraduate nursing at Idaho State University. In this series, we will be discussing the increasing problem of violence against caregivers in the home. Over 65% of our team members report experiencing violence of verbal, physical, or sexual assault during the course of their workday. This violence leads to serious physical and emotional harm. It leads to burnout, turnover, and poor quality of care. Join us as we explore the risks and we discuss some improvement strategies that we as an industry can do to help our team members. I'm thrilled to introduce my first guest, Andrea Devotie, the Executive Vice President from the National Association of Home Health and Hospice. And Andrea, thank you so much for being here today.
It's great to be with you, Danielle. I'm looking forward to our discussion.
Thank you. And I have to start us off by drawing attention to the call to action that NOC produced just a few months ago that addressed this topic and really invited the rest of us to join in a national conversation about violence in home care. Andrea, can you tell us a little bit about that project, how it got started and what motivated it?
Be happy to, Danielle. And I have to give thanks to Johns Hopkins Home Care, who were very instrumental with putting out our final product and helping us. But this issue's been near and dear to my heart for years. I am a nurse for longer than I care to admit. And workforce safety is the dirty little secret of healthcare. Unfortunately, since the pandemic, when most things moved into the home, we became more and more aware, and safety was more and more talked about, rightly so, and became of grave concern to our members and our board. So working with Johns Hopkins, we decided we really wanted to do something for our industry. And the only people that I felt I needed to go to was our members, because they're the experts out there every day, pounding the pavement or grass, whatever. And so I had a very committed group of people that are still meeting.
Yes, that's so wonderful. And I really appreciate your phrase, the dirty little secret, because there are so many aspects of this that need to be recognized and acknowledged. I think the whole country has had a couple very high profile home health nurse deaths, with Douglas Brandt losing his life in Washington back in December of 2022. And then Joyce Grayson also being killed in the course of her work in Connecticut in October of 23. These are two very high profile cases. Did these have influence in NOC's progression in your work with this group?
Oh, yes, of course they did. But I have to be honest with you, in the lobby of our building is a statue that has been there since 1984. And it was in memory, and I cannot tell you the woman's name, but it was in memory of a woman that was killed in home care in the United States, donated by her colleagues to the National Association. And seeing that every morning made me think about it. And then these two unfortunate instances really brought it home.
They really, really do. And thank you for reminding us that this isn't a new phenomenon. The data tells us this has been going on for a long time and growing worse. I think one of the things that's most challenging for the home health industry is struggling with the data. We have reams of data about hospital-based safety issues and very, very, very little about home health. What little we do have shows that rates of violence against healthcare professionals goes up in steps, with ambulatory care being the least risky, hospital care exceeding ambulatory care by almost double the risk. Long-term care has a 75% greater risk for violence against the employees than hospital-based care does, and home care tops all of them. Mm-hmm. By some reports, home health is the second most risky place for an employee, next only to law enforcement. Those are staggering numbers, aren't they?
They're staggering. They're so frightening. And it's been so refreshing in a way, and that we have somehow gotten some of our people to begin the reporting mechanisms. And I know we'll talk more about it later, but that whole culture of being out of the focus of an industrial complex has made things so much easier for people to abuse.
You know, I think that's a fascinating conversation. I'd love you to talk a little bit more about the conditions of working in home care that you're referring to.
Working in home care of any kind, and actually it extends to other people that are also tangentially related to home care. We have Uber drivers, we have pharmacy delivery people, we have home health, medical durable equipment. I said that backwards, but that's okay. Anyone that's going out is at risk. And I believe that people are in their home setting and they are very comfortable with being themselves. And those people are our patients and caregivers. We as healthcare providers are going into a totally uncontrolled setting for us. Whereas in the other industries that you mentioned, Danielle, hospitals, long-term care facilities, even ambulatory care, there can be protections. All we have available to us is the availability of asking ahead of time for them to secure their facility of any risks to our workers. But that's an honor system.
Yes, yes.
And that's what is so frightening, that we are just beginning over the past year or two to acknowledge and talk about and educate on.
Yes, that isolation. When a person is working in someone else's home, they're completely alone. We rarely send two team members together. That's a organizational challenge that we'll talk about in a subsequent episode. But most of our home health team members are out alone. And we have to take into consideration every kind of neighborhood that they go into, from economically disadvantaged urban areas to very rural areas where staff might be driving for 45 minutes between visits. There are places, I live in Idaho, you can drive quite several miles between houses, and in some places much further than that if you're in ranching and farming country.
Right.
The isolation is a significant difference in home-based care.
And the risks and dangers to all of those people within whatever kind of community it is also makes this an issue not only for the industry, but for the communities that they serve.
Yes. Tell us more about that.
It's very important that people providing home-based care realize that they do have a community around them that can be of benefit to them. But in isolation, you don't include that community. So the community may be, is there a community watch in an area of a city that's particularly dangerous? Did you change your schedule and not notify the scheduling department of the company that you were switching people and wouldn't be on route X, you'd be on route Y, particularly for people that are traveling by car in both urban and rural? I mean, if you ride off the road and in a ditch and we don't have you going to that person, we may never find you on that 2-hour trip. So there are so many risks where involving making sure that your police department knows the areas that you serve, and not the individual provider. The leadership needs to create the community in which their employees work. And that is what the call to action really wanted to focus on, those pillars of developing that community.
I'm really excited to get into those pillars. Before we get there, I'm going to dig just a little bit further into this concept you brought up about the various communities, because this concept of isolation and the way you're reminding us that as home health team members and caregivers go to homes, we have multiple levels of isolation. They're typically working in isolation. They're often working with people who feel isolated, who are homebound, and may or may not have large groups of people or communities that they can rely on for support. And then in addition, their homes are located within communities. And how does the agency connect with the community and the community resources? There's so many layers of that I think it is, as we extend into discussing, well, how does a leader even approach this? It's worth noting all of those. I also wanted to just bring up a little bit about the patient populations that are most commonly seen in home health care. I think it's a very common idea and largely a misperception that it is a person with a psychiatric disorder who poses violence. And
Correct.
That is not untrue, but it's limited in its understanding, because the research also tells us that the bigger issues are any kind of cognitive impairment, which includes dementia. And that geriatric patients experiencing dementia who are also utilizing medications for mental health disorders and experiencing limited mobility are very, very, very high risk people to
Yes.
be acting out in violent ways. And correct me if I'm wrong, but this sounds a lot like your normal average home health client. Am I in the right place here?
Absolutely. You're in the right place. And also, the fact is not, when we talk about violence against healthcare workers in the home, it's not always the patient that is the person committing the violent act. It is not only, it could be anybody. It could be the caregiver. It could be the extraneous family member in the home. It could be the neighbor. It could be, I'm sure I'm missing 400 possibilities. And that's what makes it so important that we make sure that our staff know that they need to engage their personal community, their organizational community, and the community they're in. And so many of our workers, Danielle, they like working in home care or home-based care because they are serving their community. They need to capitalize those resources, and they need to not want to be the Lone Ranger, to show my age, but be out there on their own, doing their own thing, but depend on all the tools, technology, but the simple thing of communication.
I think that everything you're saying is supported in the researchers. What little bit we have, there is research drawing a direct link, at least in the hospital setting, between The reduction of workplace violence, the reduction of burnout, the improvement of patient quality, and things that the team members report when they have strong team communication, when they have support from their leadership, when they have strong handoffs and transitions of care. Those cultural behaviors lead to fewer incidences of violence. And I think you just brought that right into home-based care and really challenged all of us to say, when you work alone, how do you build a sense of teamwork and community? Right. So let's talk for a minute, Andrea. Let's go back to the call for action and the 5 pillars. And because I think those are so important for our audience to learn about, and will really help us to put this in context of how do we approach the problem.
Okay. I alluded to it, Danielle, and I think that everyone really needs to focus on the organizational leadership, the culture of the organization, the leadership, and the policies are the beginning factor if you're starting to look at your organization afresh. Every organization has a culture, and they need to have a culture of safety, and they need to have priorities of safety. Safety can no longer be something that you do once a year for the accrediting body before they come in, be a policy that's a piece of paper that's stuck in a book on a shelf. It has to be a living, breathing document, and that document can't only reside in administration. We need to start with our employment agreements and orientation and move forward so that everything is communicated from day one. But then the secondary piece, because I don't want to go to the next pillar yet, is we have to have that organization leadership walk, talk, breathe, and listen. Because one of the biggest issues that comes up is that they talk about safety, but no one listens to me or no one follows up, which is why it's been our dirty little secret in the industry probably since Florence Nightingale and Clara Barton, and before that when they were working the projects in New York and everywhere else. We need to talk about what's going on and then make action and change that living, breathing document. But it needs to be reported. Those incidents need to be reported to the board of directors, to the governing body, whatever organization type you have, the president. So that's the beginning.
I'm so appreciative of those words. I think that this conversation about leadership and culture is really where we will go in episode 2, because it is the absolute critical part of this. And I think what really resonates here is the recognition that, as you said earlier, we can't control the walls. When you have a physical building, you can make choices about the lighting and about who enters the building. And you have a different level of environmental influence and control. When we're going into people's homes, millions of them across the country every single day, organizational leadership cannot control that. We cannot control whether it's even safe to walk across the floor or whether the animals are safely maintained when we enter. We can't control whether there are loaded weapons in the hands of people who are not sharing the same cognition. Right. And so it does lead to a grave question of, but what can be done? And I'm so appreciative that the very first thing NOC is saying is that leaders can start to listen more attentively and actively engage in culture. That culture isn't, okay, we wrote a policy, we passed our accreditation inspection, but it is actually an active process involving the entire team.
And encouraging the team to participate in the development. It's the team that is out there day to day in 3 to 6 homes, depending what they're doing for the organization. It's so important. And it's so important in giving the feedback. It encourages people to speak up, because the other thing we have always condoned is that our home care workers never reported anything because they were made to feel that they were the one at fault, that they had precipitated the act. That's not the case. This is a tango. This is 2 people together interacting. We need to support them, to encourage them to join us.
And with that, I am going to wrap us up for session 1 of this podcast. I think that you've made such incredibly important points that violence against home health care team members is historical, it is not new, and it is growing. And we have a very risky work environment. It is also something where change can happen. This is not beyond our influence or control. That when the team members, the caregivers speak up and share their experiences and partner with leadership in a true listening, sharing environment, then change can happen and we can improve everyone's safety.
And make it the wonderful place to work that it is.
And which it is 95% of the time, right?
That's right.
So from there, Andrea, I'm going to thank you so much for joining me for session 1 in this series. I am looking forward to our continued conversation in our next episode, which will be all about the organizational culture and how leadership can actively engage in that to improve safety for everyone. Thank you so much. Thank you to our listeners. I do hope you'll join us again for episode 2. Have a great afternoon.